Hello, I'm Dr. Bruce Patterson. I'd like to thank the organizers for inviting me to this meeting. I'm a viral pathologist and the CEO of InCell DX. Today, I'm going to talk about our validation of our novel long COVID diagnostic with new unsupervised machine learning algorithms that can distinguish long COVID from acute COVID, chronic Lyme, and ME/CFS. I will also describe how machine learning modeling informed us of the immunopathogenesis of long COVID. In addition, I will demonstrate how using a precision long COVID diagnostic led to potential therapeutic targets that we are now taking through FDA trials. And last, I will report preliminary data on treatment studies which correlate symptom improvement with biomarker expression, which is absolutely critical in a disease that has such overlapping symptoms with other chronic inflammatory conditions. Long COVID affects 20 to 30 million Americans and over 100 million worldwide. Long COVID PASC represents a healthcare and economic emergency that has to be addressed at the highest levels. Our data has shown that PASC is a vascular inflammation caused by persistence of the S1 protein in pro-inflammatory white blood cells months and now over a year post-infection. However, a similar pathology may exist in patients with chronic Lyme, fibromyalgia, ME/CFS, post-vaccination injury, and the need for a diagnostic to separate these entities is paramount. When we first started looking into acute COVID in February of 2020, we used a biomarker panel of over 158 markers, both serum-based, plasma-based, and cellular-based. And after that study, we narrowed down our biomarkers by machine learning and AI to really focus on four important arms of the immune system: innate immunity, adaptive immunity, humoral immunity, and damaging immunity. In our first paper, we found that acute COVID causes immunosuppression. As you can see in panel B, the levels of CD8 T cells are in the teens, if not in the single digits, when the normal range is around 30%. We found a significant increase in the CD4 to CD8 ratios. And in addition, these T cells were both exhausted by PD1, CTLA4, and TIM3 staining, and most importantly, these CD8s by transcriptomics had very low levels of granzyme A. So in essence, we found profound immunosuppression having to do with acute COVID. Well, what does that mean? Well, acute immunosuppression by COVID can cause reactivation of chronic viral infections, especially the herpes family viruses, and it can also cause recrudescence of tick-borne illness in patients who are inadequately treated or undiagnosed. So I think there is a discrepancy in the terms that we're using for long COVID. PASC, which is post-acute sequelae of COVID, could encompass an exacerbation of ME/CFS as evidenced by finding the chronic herpes family virus reactivation, or even recrudescence of Lyme infections or Lyme-associated infections. In addition, long COVID, I think, is a distinct entity in of itself, where COVID itself can cause a chronic or long version in the absence of herpes viral reactivation or tick-borne disease. And in fact, one has to be cognizant of the timing of evaluating long COVID. As we showed in 2021, one can see viral mRNA shedding and replication in the first 3 months following acute infection in patients with impaired CD8 T cell responses. And in fact, more than half of the long COVID patients that we see have either decreased CD8 T cells, exhausted CD8 T cells, or still continue to express low levels of granzyme A. So what does that do? Well, long COVID, of course, constitutes a significant number of symptoms that we're all well aware of. Fatigue, brain fog, post-exertional malaise, joint and muscle pain, etc. However, designing diagnostic approaches or using that criteria for diagnosis is difficult because of the overlap, as I show here in red, with chronic Lyme, for instance, which also has fatigue, brain fog, post-exertional malaise. Or ME/CFS, fatigue, brain fog, myalgias, neuropathies, etc. So one has to take into account that symptom-based diagnosis is not going to be specific for long COVID itself. In addition, we also found in individuals post-vaccination with no signs or indications of COVID infection that some of them, again rarely, have long COVID-like symptoms, also consisting of fatigue, brain fog, neuropathy, POTS, and others. And so here we are with this conundrum of post-infectious and post-inflammatory conditions that are present in great numbers across the United States and across the world. So that led us to develop the first generation of our diagnostic for long COVID, which we launched in Europe in September of 2022. Is now being run at and validated at reference labs in the United States, and has become very useful, as I'll explain in a moment. As I said, machine learning and AI allowed us to reduce the number of biomarkers from 158 to 14, including TNF-alpha, interleukin-4, interleukin-13, IL-2, etc., into a panel that is done simultaneously in only 25 microliters of blood, which will allow us to, as we're working on right now, be able to develop kits where blood sampling can be done at home. And in our first paper in 2021, we published these algorithms that allowed us to separate long COVID from acute COVID, both mild to moderate and severe acute COVID, which are represented by the dashed lines. In yellow, you see long COVID individuals separated with two algorithms, a long hauler index, which is interferon gamma plus IL-2 divided by CCL4, and a severity score, which is interleukin-6 plus SCD40L divided by 1,000 plus VEGF and IL-10 divided by interleukin-2 and interleukin-8. And that's led to the following panel, which is now commercially available, where we look at all these biomarkers independently, these cytokines and chemokines. But what does this panel mean? First thing we look at is the long hauler index. Anything over 0.65 in our validation studies, and now over 10,000 patients, we'd be able to confirm that these individuals have long COVID. The second thing we look for is this combination of three markers, SCD40L, CCL5 or RANTES, and VEGF, which are indicative of vascular inflammation and platelet activation. Last, we look for another group of markers, interleukin-13, interleukin-8, and the long hauler index as a quick determination of whether or not they might have chronic Lyme disease. So what does this all mean in terms of vascular inflammation? Well, in our first paper, we demonstrated that there was an increase, significant increase, in non-classical monocytes, which are a subpopulation of monocytes that are part of the group of classical monocytes, intermediate monocytes, and non-classical monocytes. They all have different functions in the immune system, and they all express a variety of markers on their cell surface. Most importantly, the intermediate non-classical monocytes express the receptor CCR5, which in the past had allowed them to be infected by R5 isolates of HIV. these monocyte subpopulations are also infected by HCV, Zika, dengue fever, West Nile virus, which allows these viruses to be disseminated throughout the body. And with non-classical monocytes having a propensity to bind to blood vessels through the fractalkine receptor pathway, leads to vascular inflammation in all these blood vessel markers. In fact, there was an interesting story that was told to me by a cardiologist that there was a surge in atherosclerosis following the 1918 influenza pandemic. And what's interesting to think about is that the influenza infection may have led to increases in non-classical monocytes, bind to blood vessels, cause vascular inflammation, and of course, what the figure that I'm showing you is coming right out of the atherosclerosis literature in the early 2000s. And what we found in this paper that we published in 2022 was twofold. Number one, we found fragments of RNA 12 to 15 months following infection in patients with long COVID. We also found S1 protein in the non-classical monocytes and intermediate monocytes in both long COVID and in some patients with severe acute COVID, which leads us to believe that potentially this accumulation of S1 in non-classical and intermediate monocytes may be a predictor of who may develop long COVID down the road. Now, a recent study in Nature corroborated that the median level of non-classical monocytes, the CD14 low, CD16 high monocytes, were statistically significantly higher in the long COVID group than the chronic or in the control group. And that's an important finding and corroboration because I think these are at the heart of the endotheliitis and vascular inflammation that we see in this disease. We, of course, sorted those S1 containing monocytes and performed proteomics where we confirmed the presence of S1 in these sorted cells by mass spectrometry. And we've gone on to further do whole genome sequencing of the SARS-CoV-2 genome in these cells as well to confirm that there were indeed fragments, but however, only a small percentage of the entire genome was represented in these cells, which made it impossible to create whole virions. In addition, we did the same study in whole genome sequencing in long COVID tissue, showing that in gut biopsies, we were only able to find a small percentage, up to 6% of the whole genome within these biopsies. Now, what does this all mean in terms of non-classical monocyte elevations and production of pro-inflammatory cytokines? Well, these non-classical monocytes bind to endothelial cells that produce fractalkine, and they then migrate into the blood vessels and produce the type 1 cytokines, interferon gamma and interleukin 2, which just happen to be the numerator of the long hauler index. So again, what we're seeing from a diagnostic standpoint using machine learning and AI is starting to fit with the pathophysiology underlying the chronic inflammation that we're seeing in long COVID. And for that matter, we're seeing the same kind of chronic inflammation in chronic Lyme and some patients with ME/CFS, which I'll discuss later. So what happens when these non-classical monocytes bind to the blood vessels? Well, they create this cascade that generates angiogenesis through upregulation of VEGF. And I think almost 90% or greater of our 40,000 long COVID patients have elevated VEGF. It creates vasodilatation, which can explain the head fullness, the universal sign of long COVID, which is basically two hands on the side of the head, headaches, migraines, brain fog, tinnitus. Vasodilation also causes, if you ask the patients, hot and cold insensitivity, almost every single long COVID patient has hot, cold, and sensitivity. Or they'll even show up at telemedicine with a blanket on their shoulders. That's how profound this finding is. And of course, vasodilatation can result in drops in blood pressure, increases in heart rates, so-called POTS that we're seeing in a lot of these patients, and other findings, as I'll discuss in a moment. So a lot of patients say, well, how is it these monocytes that under normal circumstances have very short half-lives? Well, the actual fractalkine receptor is required for monocyte homeostasis and atherogenesis, and it promotes cell survival. So as long as these cells can bind to blood vessels, they short circuit their apoptotic program. So that led us to really validate our findings in long COVID into a long COVID diagnostic. And yes, this has been around for over 2 years, and we've been using it successfully to triage patients into different therapies using known and some experimental therapies. But the bottom line is we looked at 370 patients, healthy controls, mild to moderate acute COVID, chronic Lyme, ME/CFS. We had a training set of 220 patients and a blinded test set of 150 patients. And we developed a diagnostic algorithm using the 14-plex kit that I just described. And as you can see, we can take all of the diagnoses as a whole. In yellow, you see healthy controls. In green, you see ME/CFS. In orange, you see Lyme. And in light blue, you see PASC. And we're able to divide into really distinct pies, if you will. PASC over here in the middle, healthy controls over here on the far left, and different algorithms that tell us whether it's Lyme or ME/CFS. And with this training set performance, we were able to achieve reasonable performances for both long COVID, long VAX, ME/CFS, and chronic Lyme, as you can see in this table. But we wanted to further refine these diagnostic algorithms because, as you can see in the previous slide, ME/CFS was across the board in terms of cytokine expression. So when we looked at a test set that only included healthy controls, long COVID, and Lyme, we were even improved performance when looking at healthy controls, Lyme, and long COVID. And what was really reassuring is when we used decision tree models and gradient booster machine learning models, we found that interferon gamma interleukin 2 pathway, again, the numerator of the long hauler index, went right to long COVID, again, also with elevation of interleukin 4. And what's really interesting is, of course, in this latest paper in Nature, they found expression of interleukin 2 by T cells, high expression of interleukin 4 by T cells. So it really fits with the models that we had developed over the past couple of years. And also reassuring was the fact that we found interferon gamma and IL-13 on the decision trees to Lyme. And interferon gamma expression is a hallmark of Lyme disease and chronic Lyme symptoms and signs. And of course, interleukin 13 has been implicated in some of the neuro-Lyme findings that patients express. So again, a lot of these paths in the decision tree are fitting with the literature. When we looked at our test set to distinguish between normal controls, PASC, and Lyme, we were able to significantly separate these three conditions and come up with a performance metric of long COVID or PASC of 98% sensitivity, 91% specificity, and for Lyme, 96% sensitivity and 89% specificity, which is really remarkable given the significant overlap of symptoms in these individuals. In addition, in this set of 370 patients who all presented with fatigue, brain fog, and post-exertional malaise, we're then able to look at individual cytokines, and we learned a lot about these chronic inflammatory diseases. Again, predominance of tumor necrosis factor, which I'll get back to in a moment, interleukin-6, SCD40L, and VEGF are very informative in terms of detecting chronic inflammatory conditions. And this nice separation between the four diagnoses, the healthy controls, long COVID, Lyme, and ME/CFS, by their overexpression of SCD40L, the first protein in the thrombotic pathway on blood vessels. Now, underlying all of this information is our ability to collect all the data on 40,000 plus patients into a data analytics portal. So we can ask the question for any of these chronic inflammatory conditions that include all their laboratory results, information from a wearable that we've developed, and also information from the electronic medical record and telemedicine, and incorporate that into a single portal where we can start applying machine learning, AI, and data analytics to really any question. And one of the questions that we needed functionally when we're seeing patients is, what is it? Is there a way for this abundance of data to inform us beyond just looking at individual cytokines? So we developed predictive diagnoses using this portal for the chronic inflammatory diseases, where we asked the data, if you will, what's the diagnosis? Non-perturbed or healthy, long COVID in the second bar, chronic Lyme in the third bar, or ME/CFS. And so this is what we see during telemedicine based on the panel. Is it most likely long COVID? Is it most likely chronic Lyme? Could it be both, where we work both of those two scenarios up? Can it be Lyme with a little bit of ME/CFS thrown in this instance? So this is a very, very important tool to take the composite of the 14-plex and answer the question, what potential diagnosis is going on here? And that's on top of a cheat sheet we created for chronic Lyme with that 14-plex. So the combination of elevated interleukin-8 plus interferon gamma, or interleukin-13, or elevated interferon gamma, or a long hauler index above 6, really are three very high-performing criteria for chronic Lyme, and in those instances we reflex to tick-borne organism, two-tiered serology. Now, I've danced around the topic of ME/CFS, and I think all of you out there can understand why. It's a very heterogeneous group of patients that may have any number of different etiologies, and that's why I like to talk about pure long COVID, chronic Lyme, because they're separate entities. They can be tested for. ME/CFS, as we've seen in the literature over the years, can be just about anything. And indeed, when we went back to our data analytics portal and looked at 50 ME/CFS patients diagnosed by CDC criteria and came to us with carrying an ME/CFS diagnosis, we found that there was 5, if not more, clusters when we did immunotype clustering analysis. And we asked the question, how are these different? And this is data that we just came off the presses a couple weeks ago, so we're still investigating what's going on in these individuals. But what we were able to do by going back to the data that we had stored is looked at the cytokine profile and cytokine differences in these ME/CFS immunotypes. And as you can see here and in the next few slides, every single immunotype is very different in terms of their expression. So here's TNF-alpha expression. Immunotype 5 has very high levels. 1 and 2 and 3 don't have very high levels. Here's interleukin 2, where immunotype 4 has very high levels of interleukin 2. 1 and 2 do not. Here's GM-CSF and SCD40L. Again, immunotype 3 and immunotype 2 have elevations in SCD40L. In terms of CCL5 or RANTES, cluster 3 or immunotype 3 predominates with CCL5 expression. Immunotype 4 with CCL3 expression. And again, as we go through, interleukin 6, high in cluster 3, and low in cluster immunotype 5, which had elevated numbers of other cytokines. So we're completely intrigued by these findings, where we have at least 5 different immunotypes that have come in with diagnosed with ME/CFS by classical means, who happen to have completely different immunotypes, and we're now looking into symptoms and presence of potentially other chronic herpes family viruses, other viruses, other potential bacterial causes. So it's all very exciting as we're trying to untangle this web of ME/CFS. But this analysis also taught us some things that we can use diagnostically. So for instance, IL-2, IL-6, IL-10, and CCL5, as their values increase, the probability estimates of long COVID increase. As interleukin 13 increases, as I mentioned before, the estimates of long COVID decrease, but obviously the estimates of chronic Lyme increase. Again, interferon gamma and the long hauler index, as they increase, probability of long COVID increases. TNF-alpha, as TNF-alpha increases, the probability of long COVID actually decreases, and I think decreases relative to ME/CFS and chronic Lyme, not decreases relative or even approaching normal levels. So what has that done for us? Well, these diagnostics, our data analytics platform, have informed us for drug discovery. And when I think about these chronic inflammatory conditions, I think about antecedent infections leading to inflammation, leading to symptoms, leading to targeted treatment. Targeted treatment informing us on how to lower the inflammation. And in the best of all worlds, we would see a improvement in symptoms with targeted treatment aimed at particular cytokines. And in fact, that's what we tested in this study that was published in Frontiers of Medicine in February, where we used a combination of Maraviroc, a CCR5 antagonist, and a statin to see how that would improve both the symptom scores of long COVID, the Rankin Neuro Score, Compass Dysautonomia, NYHA Cardiac, shortness of breath, and most importantly, the severity, the fatigue severity score. And what we did, and the reason we chose Maraviroc and statins was because of the vascular inflammation. There's a common misconception that we're using Maraviroc as an antiviral. Well, number one, it's not an antiviral. Number two, it's an entry inhibitor for HIV, which I think, frankly, was a little bit of a fluke. As CCR5, the CCL5 pathway has exquisite role in the immune system in terms of sending immune cells to areas of inflammation. So because of that, it's heavily involved in the metastasis of cancer. CCR5 blockade elegantly reprograms monocytes macrophages to a non-inflammatory phenotype, hence lowering interleukin-6 very quickly, lowering TNF-alpha very quickly, which, as I mentioned, are elevated in long COVID and, frankly, these other chronic inflammatory conditions. And what we found in this paper was, number one, that, and we were surprised, all 5 symptom scores improved with statistical significance. And then we were able to correlate the symptom scores with various biomarkers. So yes, there are biomarkers in long COVID. Yes, there are biomarkers that correspond to symptoms in long COVID. And in terms of severity score, fatigue severity score, what was very exciting, at least from a scientific finding, not so much for the patients, obviously, was how interleukin-2 and TNF-alpha highly correlated with fatigue, with very low p-values. And so when I see a patient with elevated TNF-alpha, and I don't care what it's from, I know if I can bring that TNF-alpha down by reprogramming monocytes macrophages with a CCR5 antagonist, and then using a statin to downregulate fractalkine and keep these non-classical monocytes from binding to the vascular endothelium and causing vascular inflammation, then that's putting us on the road to recovery for these patients. And another word about TNF-alpha. So there's a lot that came out in the news about serotonin and serotonin levels in long COVID. Well, yes, one of the most profound factors that lowers serotonin is chronic inflammation. And in particular, IL-1 beta and TNF-alpha cause decreases in serotonin levels. So, at the end of the day, we have to figure out what is treating a sign or a symptom or a end result of the chronic inflammation versus what we're trying to do, which is treating the actual source of the chronic inflammation in terms of therapeutics. And that's really what we've embarked upon. And again, here are the changes in symptom scores, highly statistically significant for the 5 symptom scores that I mentioned in the 20-patient study or 18-patient study. We then went on to do 314 patients pre and post Maraviroc and Pravastatin in long COVID, and also found profound statistical significance in the lowering of biomarkers. TNF-alpha, 10 to the minus 12. Long hauler index, which is IL-2 plus interferon gamma over CCL4, 10 to the minus 6. We have a biomarker that demonstrates a correlate to improved symptoms. And that's what we used in this study on 314 patients treated with Maraviroc and statins. And if we looked at individual cytokines in this study, we found significantly decreased CCL5 or RANTES, which would be expected, significantly decreased interleukin-2, but most importantly, the long hauler index has stood the test of time over 2.5 years since we first presented it as a diagnostic for long COVID, and it is reduced statistically significantly in 6 to 12 weeks by this drug combination. And of course, the obvious question is, where do you go from here? Well, today we present a long COVID diagnostic that distinguishes between long COVID and chronic Lyme. Yes, there is one. ME/CFS deconvolved into at least 5 immunotypes with distinct cytokine profiles, and we're currently investigating the symptoms and infectious histories of each subtype. And our precision diagnostics and data analytics portal with machine learning and AI has provided a novel, robust drug discovery platform for chronic inflammation and cancer. And last, like I said, our RCT for the use of Maraviroc and atorvastatin in treatment of subjects with long COVID has been completed in terms of trial design and submitted. So we're very excited to get started, and I thank you for your time. Thank you very much.